Welcome, listeners. Happy 2026. I am joined today by 3 experienced diversion mitigation specialists who I am also fortunate to call friends. And I am very much looking forward to this podcast, our first of 2026. During a recent conversation, one of them mentioned feeling that at times, because they have a nursing background, they perceive that some believe that they are less qualified to lead a diversion program. In other words, because they're not a pharmacist, it's why are you in charge of the program? And so this sentiment is actually what inspired the idea today for this podcast. We're going to talk this out. With me today are Bethanie Gamble. Bethanie and I will be representing the pharmacist perspective in this discussion. And we also have Mary Nelson and Alecia Pittman joining us, both of whom bring their valuable experience as nurses. So I think a first good step would be for each of you to share your background and how you ended up in your current role, which is most of the time not a straight line, right? So let's start with Mary.
Okay, well, I'm going to take us way back to my bedside days, believe it or not, and talk about one of my first exposures or experiences with drug diversion. Happened to be in my own department that I was working in at the time, and I unknowingly investigated this drug diversion, kind of figured out that we were having an issue. We had all of the telltale signs. We found paraphernalia in the bathroom. It was kind of the start of that. And then just kind of observations and, watching what was going on in the department, who was working those days. That it happened twice that we found paraphernalia. And I actually figured out who it was. And was able to report that to leadership, and it took a little while, but it did, and it eventually stopped. The person was stopped from the drug diversion scheme. Skip forward a few years later, when I was away from bedside and working in patient safety, we had a consultant come to our organization to assess our drug diversion program around our organization, which we didn't have an official program at the time. And I escorted her around my hospital and got to know her, and she was a nurse. So when her recommendations came to our organization to start an official program and hire someone to run that program, I thought, why not me? I had lived experience. I was working in patient safety and learning process improvement at the time. So I applied for the job and got it. Here I am.
You're a born detective. So
yes. Almost 9 years later. So
yeah. All right. Great. Bethanie?
Yeah, so I was in residency at the time, and I kind of had somewhat of an admin focus, like working on projects, operational things within the pharmacy. And when I was finishing up my residency, there was this opportunity for this role, which at the time was kind of hybrid diversion. Didn't even know what diversion was really. And also kind of regulatory, joint commission compliance, and some policy coordination stuff. And they said, hey, would you be interested in this? And I said, sure. And then, of course, over time, that hybrid role then turned into a full-time diversion role. And I've been doing that for about the last 10, 11 years ever since. So kind of fell into my lap, but very much spoke to my core interests.
Okay, very cool. Alecia?
So similar to both Mary and Bethany, my path to drug diversion wasn't something that I planned. It kind of found me. I was involved in a situation that made me realize just how vulnerable our team members and systems could be when it came to medication safety. I didn't understand much about diversion at the time that I stumbled upon this. I can't share a lot of the details, but the experience, it made me want to be part of the solution. It was a heartbreaking situation. And now as director of drug diversion and prevention, I get to work across disciplines to protect our patients, support our team members, and strengthen those same systems. Again, I really just fell into it, and I had to grow into it as well. So it's been 5 years of really learning the ins and outs of everything drug diversion and prevention. I've loved every minute of it.
Very great. Mine is a very different story than the three of you. You wanted to go in that direction when the opportunity came up. Mine was, I'd been in pharmacy doing all kinds of things, but at the time I was clinical and I needed a schedule change. That's really what it came to. It's like I needed school hours. I think some of you have heard this story before. And so I went to my leadership and said, I need a schedule change. You got anything where I could work between like 8 and 3? There's no pharmacist that works between 8 and 3 in a hospital, right? And they said, yes, actually, we need somebody to take over the controlled substance monitoring and diversion monitoring because that person was retiring. And for me, it was this is horrible. But, beggars can't be choosers. And I cannot believe they actually said yes. So it's like, okay, I'll take it, right? Got condolences from my coworkers. And that's how I started. And I found that I absolutely loved it and would never go back. So yeah, different story than the three of you. But now we're all in a place where we're very passionate about what we do. And we really enjoy it. So I want to just a little disclaimer to our listening audience. These women that I have here are some of the most open-minded, really very conscientious women. And so if we say something and forget about some group of people that should be included in this, it was not intentional. This is just us kind of talking it out. And we recognize that there are analysts that have no experience, no professional license, and their core background is analyzing, and they do a fantastic job. There are pharmacy technicians that do fantastic jobs. There's previous law enforcement history that get involved in the investigations and do fantastic jobs. And so our focus today is going to be primarily nursing pharmacy, but we recognize there are other groups of people out there that also do fantastic jobs. So let me start that with the first question. Do you feel that a particular license makes somebody more suited for this type of position, or are there other factors that are actually more important? And so I'll start with Bethany.
Yeah, sure. I mean, I think when you're talking about the core of the diversion team or the leader of the diversion team, having a clinical background, working in a hospital is rather important because that's the area that you're responsible for. So whether that be a nurse or pharmacist or possibly someone from anesthesia, I do think that that's important. It provides a baseline working knowledge of what the workflows are, medication use, safety, how patient care operates within the hospital. But I don't think that isn't to say that the entire diversion team needs to have this background. I mean, there are strengths with having others on your team from different professions. And I really think that what you're seeing with the healthcare systems who are prioritizing growth of their diversion team, you're seeing this. So you're seeing pharmacy technicians as part of that team, someone who maybe's worked in law enforcement or security, and especially with the way technology is going, someone with an IS or an analyst background is very beneficial and brings strengths to that program. So I don't think that it's necessarily one degree or certification over another, but I do think having someone with that clinical hospital background is rather important.
That makes sense. Yeah. Alecia, anything you want to add to that?
Sure. I think licensure, of course, provides a strong foundation for this position. I think each of us bring things to it. But I think success in diversion oversight goes beyond credentials. And like Bethany stated, there's a whole lot to it, right? Attention to detail, persistence, a lot of persistence, comfort with ambiguity. There's so much of that. I often say that I'm traveling down rabbit holes, and people say, well, aren't you just making that up? I yes and no. I'm really using past issues, past concerns to go forward with that. Empathy, diplomacy, right? You have to be very comfortable with conflict. Skill in navigating organizational barriers is something that you need to have. I think that lands outside of licensure. I think that these traits, I think the traits often matter more than the license itself. And I think you see this with effective leaders, right? They build trust across disciplines. They stay grounded in purpose because of some of these things or all of these things.
Mm-hmm. Yeah. Mary, anything you want to add?
I think what I would add is, it would be for all of us, I think we would love to have a dual pharmacy nurse team, but that's not necessarily available to everyone. It certainly isn't in my organization. At this point, our program is not resourced to do that. So I think that what it becomes really important is that collaboration and that teamwork. Because there are certainly things that, I don't know that I, have learned over the years, but I need support in when it comes to internal pharmacy operations. I've learned so much about DEA and regulations over the last 9 years. But that collaboration across the lines is super important for a drug diversion program. And I think that would go for, any licensure or any specialist that is, running a program has to use their resources and, make it teamwork.
Yeah. And I think you've all touched on important things. And Alecia, you mentioned the other skill sets that are necessary, right? So we'll talk in a minute about what the nurses feel is their unique piece that they can bring to the table versus what the pharmacist, Bethany and I, bring to the table. You're right, Mary, a combination is fantastic because then you can play off of each other and learn from each other and fill in the gaps for each other. But Alecia, you mentioned the other things to stay grounded, to be detailed. Let's talk about that a little bit because I agree, Bethany, the clinical background is important when whoever's in charge, because whether it's, you have software and you're looking for improvements and things just aren't working with certain data feeds and what have you, you have to have the background to understand why is this not working? Why is it not translating right? And without that clinical background, you really have a disadvantage. Because you don't quite understand the whole workflow. So clinical background is important, but not every pharmacist or every nurse would make a good diversion specialist. So let's talk about that. What do you think are, collectively the skills that we each have that make us suited for this type of position? Mary, you want to start that one off?
Yeah, I think, Alicia's touched on it a little bit with our analytical skills. It really takes a lot of patience with very tedious data to be able to look into any drug diversion investigation. It takes a lot of focus. But I always go back to that collaboration. I think it takes someone who is willing to be open to input from leaders, to hear from them, and to have that trusting relationship, I think is super important. So, I think that is outside of our clinical licensure, those things, are important, and to have a level of curiosity, and to be brave. Sometimes we have to have very difficult conversations in our roles. And so I think, asking those questions, being curious, and at the same time being, compassionate in those types of conversations that we're having is very important in our role.
All very important. Bethany?
Yeah, I think that as well. I think, you can have the most well-trained, again, speaking as being a pharmacist, but if you are lacking the drive to wanting to dive into things, it's going to be hard. You have to dive into the data and dive into what other data you can then relate to that data. You have to ask questions, but then keep asking those hard questions in a different way, often multiple times. And you also have to be willing to teach and then reteach and then follow up, stay focused on those projects. Again, not just thinking about investigations, because a lot of times on the project side, others are probably not necessarily reviewing your project as the priority. And that's a lot of the workplace, right? You're competing for people's time and attention, and there's a lot on everyone's plates. So it comes down to your determination that you have, that's going to be able to drive change both within your projects or to push your investigation forward.
Mm-hmm. And to do it all without irritating leadership.
Yes.
Right? I mean,
Sometimes
I'm sure we
nice to
irritate
possible.
sometimes. Yeah, exactly. Alecia, do you want to add anything else?
I think you covered everything. Both of you did a beautiful job with that. I think the clinical insight and the operational awareness sort of marries each other in this case. And I think we have to be really, really aware of what you just touched on, the load that is on the frontline team members, the load that the leaders carry, and that we come along and we add more to that. And sometimes, I think back, I used to get, say, 20, 30 emails a day in leadership, and I could only take care of maybe 2 or 3. So I printed out 2 or 3, I managed 2 or 3, and the other 28, sadly, sort of just, were sidelined. And I think we all need to be aware of what's going on the front lines. And so if something doesn't land at the top or doesn't stay at the top of that email, that we have to be just so in touch with that. And I think connecting with the front line and being out there and being seen and being heard is critical to our role. And I think as a nurse, that might be easier to be out there with the people I know and appreciate and work side by side with.
Okay. Yeah. And we'll talk about that in a minute. I agree with, everything that you all said. And it's that, Bethany, you mentioned, I think it was you that said asking the questions and asking another question and asking another question. I don't know if any of you, I get grief from my family because I'm the one that they'll tell me something and I'll be like, oh, well, how come, and eventually they're like, Mom, who cares? I'm just telling you this, I don't know the answer to, I'm like, oh, okay, sorry. But it's that, just that innate, that's part of me, is to ask that question, ask more questions. But it's also seeing the big picture and the detail in the small picture. And it's knowing when to ask more versus, okay, I'm done with that. I don't think there's anything there. Not that we always get that right, but I think some of that is just that innate. And I found that, when I got into that role, originally to start with, I liked that digging in and the detail and asking those questions and taking it down those rabbit holes. It's like, oh, okay, I've been doing this in my pharmacy practice, but now I'm applying it in a different way. And that's just part of who I am. And that's part of what I enjoy. So let's talk about the nursing perspective versus the pharmacist perspective. And we all know, right? There seems to be this weird butting of heads between nurses and pharmacy in the hospital, which, that's a talk for another day. But it's like, what is going on there? And why is it like that, right? Because we look at things very differently, I have discovered, and we approach things differently, but we're both very important in how we look at things. So as the pharmacist, the way we look at things and our knowledge inside the pharmacy is perhaps, usually unbeknownst to the nurse because they spend no time in the pharmacy, right? On the flip side, the pharmacist does spend time up on the nursing unit, depending on what their experience, their previous clinical experience is. So they have some insight into what is going on, whether their perception of how much insight they have is accurate or not. That is an interesting, I may think I know what's going on up there, but it's like, nope, you have no clue. So let's talk about that. Alecia, from a nursing perspective, that's your background. Where do you feel that maybe you are lacking in the medication management piece of it from a pharmacy perspective? Or do you feel that you are? Or have you learned over time because you've partnered with someone in the pharmacy, even though they're not part of your program, they've taught you? Like, how do you see that?
Oh, absolutely. I've been taught by my pharmacy team members. That was not something I knew anything about, or none of that really came naturally to me. What actually very little in drug diversion and prevention came naturally to me. But I think if I stay with my nursing side of things, I see it's interesting. I see that in the nurses on the floor when they report concerns and they have issues, they're very in tune. Even if they don't know that they're in tune with it, they're very in tune with the behavioral cues, the dynamics of things on the floor, how people are working together. They, even though they're not aware of it, they pay attention to those changes in mood, behavior changes. Maybe they came in, they appeared differently than they did the last couple of weeks. What's going on with you? I think nurses bring that. You often will hear it was just one subtle clue when it was just one slight subtlety that a nurse noticed in a patient change in behavior that ultimately saved their life. And so I think nurses bring that right into this. Even the ones who I speak to on the floor that say, well, I don't know how, I can't read that in somebody. Well, there's a lot of us, we can't really read diversion in people either. But I do think that nursing clinical judgment and the way they are in tune to really slight changes, I think that is a critical piece that nursing brings to drug diversion.
Okay. Mary?
I think that when we're talking about especially investigating a nurse, having been a nurse and felt the pressures that nurses feel and understanding the way nurses think and workarounds, I can see that, like Alecia said, I can see that in the data. I can almost feel like understanding what the situation was at the time that a nurse made a certain decision. So maybe they're falling out in analytics, but there's this understanding because I've been in those shoes, understanding what their thought process was at the time and why they made those decisions, and just understanding that patient flow and, from one department to another. So in my experience, I worked in a lot of different departments with ICU patients. I was in IR, I would go to the OR. I was in the trauma ED department. So just understanding those workflows, because I have done those workflows, I think really supports investigations when it comes to nursing investigations.
Yeah, interesting. I wonder if I would find myself taking it to an interview, whereas you might not, because you understand that workflow. It's like, no, I can see what's going on here. So you might take a different direction in terms of just a conversation of, okay, let's review this workflow. Mm-hmm. That's an interesting, from the very, very beginning. All right, Bethanie?
Yeah, so coming from, a different perspective, I think in general, the obvious, being a pharmacist and having all of the baseline pharmacotherapy knowledge is very helpful, right? And the strength when you're in diversion and making because you're having to make the judgments about doses, if they were therapeutically necessary, how are the medications given with other medications, but also, knowing the operational workflows of how medications enter the pharmacy and flow through not only patient care areas within the hospital, but also areas like sterile compounding, because that's definitely an area that needs to be reviewed from a diversion perspective as well. So things like that. But then, knowing best practices for receiving medication orders for wholesalers and all of the nitty gritty details of record keeping that's associated with that is very important for detecting another type of diversion that takes place, and often more in higher quantities when you're looking at diversion out of pharmacies, but also just other controlled substance compliance areas in general. So, and I think I mentioned it earlier, that's probably a good point of discussion as well, is, our diversion programs are not just identifying and starting investigations. A large portion of what we're doing in this role encompasses record keeping requirements, storage and security of inventory needs, regulatory compliance if you're thinking about pain scores and other patient care needs, prescribing and ordering. And then also just, again, education in so many different shapes and forms. So, I think that there's definite aspects of just being a pharmacist by training that brings about strengths in some of those areas.
Yeah, very good point, Bethany. We get focused on we suspect somebody because of the data and we go there, but you're right. A diversion program is much more comprehensive than that. It is that trying to keep you out of trouble. So,
well, and I try to remind people too, I feel bad. It's like we always talk about the nurse diverting, right? There's so many other people that we have to focus on who have opportunities for diverting. I hate it when your kind of go-to is the nurse that we're investigating as the example.
Right. Yeah. They just make up such a larger population that No, I agree. So I think we kind of come full circle and back to what you said, Mary. You need a pharmacist and a nurse for the perfect program, right? A pharmacist and a nurse with the skill sets for a perfect program is what we need. So something that the three of us have talked about before, and there's been a little bit alluded to it here, but let's talk about the complexity of the role and the toll it takes on the person who leads the diversion program. It is not an easy job, right? My husband has said to me, a good day for you is a bad day for somebody else, meaning if I have identified somebody, it's about to get, bad for somebody else to be confronted. And that's just the reality of it. So let's talk about that, the toll it takes on you. Mary, we'll start with you.
Well, I think that's what has brought the four of us together, right? Is we are often feel a little isolated in our roles in our organizations. And, I think having the three of you to be able to bounce things off of or, for support has been super important. So I think that that's where our networking in the very small community of drug diversion program managers or specialists is so important.
Agreed. Yeah. Alecia?
So I think this is a really emotionally and organizationally demanding job. I've mentioned the systems and processes. I think it's interesting. I talk about, sometimes I mention when people ask me moral distress, burnout to some degree. And I think that's what's so great about us meeting. It sort of helps with that. I think sometimes there is a sense of isolation that Mary mentioned, and we're making very difficult decisions, even if it's deciding which case to take to the DDRT. And when speaking about isolation, that said, my supervisor and one of my HR partners always reminds me, you're not alone in the decision making. So I must have needed that at some point because it's definitely stayed with me. But I think, again, I talk about resiliency. To do this well, you have to be resilient, detail oriented. You just have to be comfortable in so many uncomfortable situations. You need the support from your leadership, from peers. You need a real clear sense of purpose. I think in this position, you really need to understand, what you're doing and the why behind what you're doing. I think passion is absolutely essential. But I also think knowing when to pause, when to take a break, you have to set boundaries. And I think there's a lot of self-care needed in this program. I really do.
Okay. Bethany?
Yeah, I mean, I think the biggest thing that I didn't necessarily anticipate is the need to deliver the bad news, right? So starting an investigation and pulling together a drug diversion response team is, very official if you think about it. You have various high level leaders on a call to discuss a potentially serious matter. And the thing that I've found is this can make people feel a variety of emotions, whether it's being defensive, uncomfortable, or even like aggressively protective of their people. And ultimately what this does is it can serve as roadblocks to keeping your investigation objective. So I think that's been hard. And then also with bad news, again, thinking outside of investigations, our job is to find the things that we're not doing right, so whether that's through data review or audits of a unit or an area, when we're having to send that report to an executive leader and, to a manager about what is or is not happening in that area, that's hard because, again, you become the person that people really don't want to hear much from. And so I think that it takes a lot of energy to figure out how to deliver the information professionally with somewhat of a positive spin, but do so in a way where you're also not downplaying the findings, because again, you have to drive that change. So when things like this are kind of at the core of our responsibilities, I think I agree with time, it can weigh rather heavy, and you just have to learn how to deal with it. And then, like I say, get creative in the way that you're delivering the information. So it doesn't quite feel like you're, again, the person that no one wants to hear from.
Yeah, no, that's a good point. I mean, it's, when you walk into a room and people groan,
Yes.
because you never have anything good to say. So you have to be, in addition to everything else we do, I would find myself trying to be proactive, to be bright and smiley sometimes for no reason, right? I'm just here to say hi, what's howling? Hey, how's it going on? What's wrong? Nothing. I just came to say, you're trying to develop that rapport. So it's not always like, oh, geez, there she is again. 100% agree. We are all passionate about what we do. We've talked about that. And I'm sure you have all had a case where you have felt strongly, or maybe not even a case, but as Bethany talked about, a finding is like, this needs to change and be improved. But maybe the other disciplines that you have to work with or present that case to don't agree with you. So do you have any advice for people in this role? Like, what has worked for you? Maybe what hasn't worked for you? What have you learned over the years that you've been doing it and you've changed your approach to get your message across? I mean, maybe sometimes we don't win. We just have to let it go because others didn't agree and they trumped your card. It's like, well, nope. So let's hear about that. Let's start with Mary.
Yeah, a couple of things come to mind, Terry. I feel like presenting the data in a way that everyone understands is very important. So making that data very simple and straightforward, because we're not always talking to other clinicians when we are working with our diversion oversight or our diversion response teams, for instance. Our HR professionals are not clinicians. And so being able to present and speak to everyone on the team about the data that you're seeing, the data that we look at is very complex. And I think even nursing leaders don't always understand our data. So being able to communicate that data to all of the different folks on the diversion response team in a way that they can understand is very important. And then the other thing that I think that comes to mind is sometimes you really do have that strong feeling. I think just making that very clear to the team that, I support the team's decision, but I feel like this person is posing a risk to our organizations. That I think giving that message very clearly and getting it on the record that, I will participate and continue to very closely monitor because I am concerned, and being able to say that, in no uncertain terms.
That makes sense. Yeah. Bethany?
Yeah, I agree with a lot of what Mary said. I think kind of piggybacking off of that. So, presenting the data in a way that everyone can digest, yes. Knowing your data intimately at the same time for when you receive those pushbacks, but then draw on past experiences and past cases within the organization. Because that will provide questions that you can ask to the group, or even observations that then maybe make people rethink what they felt like were the best steps. So being able to say how in past investigations, similar circumstances were handled, and explain that also escalated steps is not the final ruling. Escalated steps are often part of the investigation. I have to remind people of that often. And I also think that, ultimately, if you have built that trust with prior drug diversion response teams where you do open up the floor, I make it a very concerted effort after I present background and data to say, I'm going to open up the floor to our members here to provide their feedback and initial impressions. I never provide my impressions first. So I think if there's that background, baseline trust that your DDR team members have of you, know that you're not always pushing your opinion first or what you think the next step should be, that also works well in your favor. But ultimately, if the DDRT goes another way, do document within your investigation notes what recommendations were provided versus what the actual next steps actions were. So that you have that as a drug diversion investigator. That's very important. We keep detailed notes. We all know that. So keep that in your notes as well. And I think the last thing that I will add is I have used a couple of these scenarios as, what we say, failures, as an opportunity to grow our program, because I have then set up follow-up meetings with, say, an executive leader from that diversion response team to talk about a particular topic. And this is outside of the investigation. So you're kind of outside of that tension, and talk about the regulations, our policy with it, and what your thoughts are, so that hopefully in the future, maybe a similar situation can be handled differently. And I think that's where your opportunity is, like I said, outside of that tension of the DDRT.
Yeah, some great ideas. Alecia?
Excellent. Both of you made great points. I agree with everything you shared. And I think, again, sharing that data, but sharing it in clinical context for the leaders that are present during the DDRT is important. And for people who are not clinical at all, they fully need to understand when you bring this to the table. I think it's not just about numbers. I try to make it a story. Again, just like both of you shared, it's about safety. It's for our patients. It's for our staff. It's not necessarily about blame, but focusing on the safety aspect. I have learned to open the door for dialogue instead of pushing for an immediate agreement. I think earlier in my career, I felt the need to push really hard on every concern. And now I do pause and I ask, I want to know, is this an urgent risk? Then we have to act on that immediately. I think we have a great team that comes together and understands urgency. I think I have to decide if there's a pattern that's emerging. When do I share that with the DDRT? When do I have enough of the story and the numbers to present? And I think I have to determine if pushing it forward will help build trust, or will it hurt what I'm actually trying to accomplish. So I've learned that timing is everything, tone and relationships are everything. I think both of you have mentioned that through our conversation. And sometimes it's just wise sometimes to just sit back and regroup. And I think that you really need to know when you need to stand firm and you don't need to take a step back. But at that point, you're going to stand on what you're saying. And again, like Bethany shared, document if there's continued disagreement with you. So yeah, I think the key is just knowing which moment calls for which of those responses.
Yes, I agree. All great points. So a couple of other traits that have come out of this that I don't think we have mentioned. One is discernment, to know when to do what. And the other is being articulate. You know, all three of you are very articulate, and that transfers into every presentation meeting that you have, because you're laying out those facts for clinical, non-clinical people that have biases and have something to lose and are defensive, but you have to be able to articulate all to those different audiences. So I think that's fantastic. All right, that wraps it up. Ladies, I want to thank you very, very, very much for your time.
Thank
Thank
you.
you. Thanks for inviting us. It was an honor, Terry. Thank you.
Thank you.
See y'all later.
Bye.
Bye-bye.